We don't have a lot of time. We appreciate your taking the time here to understand the new edition of the ASAM criteria, which has really been out since 1991. We had a second edition in 96 and the second edition revised in 2001, and then this current new edition that came out in 2013. And I'm going to sort of quickly walk you through what we're trying to achieve with them, some of the new changes, but then in particular try to relate this to drug court and criminal justice populations, and hopefully we'll have a little time for a discussion. What the ASAM criteria has tried to do since its beginning is really to move the treatment field from complications-driven treatment, where we just take care of the complications of addiction, whether that be in an emergency room or in criminal justice, where we just perhaps lock somebody up for the illegal behavior they've been involved with. But if that's been due to the illness of addiction, obviously just locking people up doesn't increase public safety and decrease crime and legal recidivism if we don't take care of the illness that is causing the behavior. And so from the very beginning, the ASAM criteria has promoted individualized, clinically driven treatment, where recognizing that addiction is a brain disease that has an impact on people's physical health, their mental health, their social functioning, their functioning in society, and their spiritual health, that we then provide a multidimensional assessment along 6 dimensions. And the ASAM criteria is really promoting assessment that leads to identifying what is this particular person's severity of illness and level of function, so that we can develop an individualized treatment plan that incorporates a variety of modalities. Modalities meaning different strategies from different schools of thought, so cognitive behavioral modalities, medication modalities, individual therapy modalities, group therapy, family therapy, working with cognitive behavior therapy, a variety of different models to have an individualized plan that's based on the severity of the person's functioning, looking at the 6 dimensions that I'm going to go over in a second, and then looking at, is the person getting better? So it's outcomes driven. Are they improving in their functioning? Are they improving in a way that we think they will be able to not commit further crimes, where they will be able to actually function in a way that increases public safety and safety for children and families? And that the individualized treatment plan then is based on an assessment of the 6 ASAM criteria dimensions. So if you have these slides, this would be slide number 5, where the 6 dimensions are as follows. The first one is acute intoxication and withdrawal potential. And what that means is that we're looking at, to what degree does a person need detoxification services? Now, actually, in this new edition, we have changed terminology away from detoxification services to be considering what does this person need in terms of withdrawal management services, because the liver detoxifies, but clinicians and professionals manage withdrawal. Now, this is not just to be fancy with words, but it's really to emphasize that if we place people into a detox center, often in some places the most intensive and expensive level in hospital detox, and then we keep them there for 3 or 4 days to make sure they don't have withdrawal seizures, and then discharge them, and then they use again in, oh, somebody put us on hold. The point of having somebody in a detox center to make sure they don't have seizures does not mean that we've managed their withdrawal, because then they use again a week later and we say, why are you doing that? We already detoxed you. Well, actually, we made sure that you didn't have seizures or withdrawal danger, but we didn't actually manage your withdrawal. So the ASAM criteria actually has 5 levels of withdrawal management that I'll quickly review for you in a little bit. So the first dimension is acute intoxication withdrawal, where we're managing a person's withdrawal over a continuum, not just making sure they don't have seizures. And by using a continuum of withdrawal services, we can actually give a person many days and even a couple of weeks. We can give people a couple of weeks of management of their withdrawal, where we now would spend all of those resources in just a few days in a hospital level of detox. The second dimension that drives an assessment of what a person needs is biomedical conditions and complications, and that we're looking at their physical health service needs. Do they have hepatitis C? Do they have hypertension, diabetes, asthma? Do they have AIDS? What are they needing in terms of medical care, nursing care, physical therapy? Do they need help with an exercise trainer and so forth? So dimension 3 is called emotional, behavioral, cognitive conditions and complications, where we're assessing, does this person have a co-occurring mental disorder needing integrated dual diagnosis treatment, mental health and addiction treatment, or do they have perhaps what looks like a mental health problem because they're having mood swings, but that may not be bipolar disorder if they're using uppers and downers, doing heroin and cocaine or alcohol and stimulants. And so we want to make sure on dimension 3 that people get an assessment of, do they indeed have a mental health problem and disorder that needs separate mental health treatment, or could their anxiety or depression or mood swings, which is part of addiction treatment, be taken care of in the context of an addiction treatment program? So dimension 1 is looking at withdrawal management services, dimension 2 physical health services, dimension 3 mental health services, and the fourth dimension is readiness to change, where we're really looking at what is this person interested in doing. So this is talking about motivational enhancement services. Well, why is this important? Well, especially in a criminal justice population, many people are motivated to get off probation or parole or to stay out of jail or to do less time, but they may not necessarily be motivated for serenity and sobriety and abstinence and recovery. And so if we mandate abstinence as a condition for compliance with the court order for treatment, we can mandate abstinence, but what we really have to do in treatment is, if a person has an addiction illness, that we're going to have to attract them into recovery and start at the stage that they are actually at, not at the stage of change where we would like them to be. Because if it was as simple as just telling people to be abstinent and to mandate that, they wouldn't really need treatment. In other words, we don't mandate people to be non-psychotic or mandate them to be non-suicidal and mandate them to not have panic attacks. If we see that their illegal behavior is part of an illness of addiction, then by all means, we want them to have treatment because we believe that will increase public safety and decrease legal recidivism and crime if we could actually get them to have a good outcome in their treatment. And dimension 4 then is a very important dimension that I'm going to spend some time a little later on, making sure that we understand that mandating treatment means also making sure a person has treatment that matches their particular stage of readiness to change. That's what dimension 4 is about. Dimension 5 is called relapse/continued use, continued problem potential. It was originally in 1991 just called relapse potential, but actually a person may get a positive drug screen and that may not be a relapse if on dimension 4, readiness to change, they're not even interested in stopping the marijuana or not using the marijuana. So if somebody gets a positive drug screen, we really have to ask them, do you were you even trying not to use the marijuana or the cocaine or whatever drug showed up in their drug screen? And if they were not actually interested in not using, that is much more of a motivational enhancement strategy that needs to be done rather than a relapse prevention strategy. They're just continuing to use. And then we added continued problem potential for mental health issues. What's the potential this person, if they get suicidal, will become dangerous and cut themselves like they did last time? Just a reminder to people, if you would mute your phone so that we cut out background noise, and then when we open it up for discussion, unmute then. And then dimension 6, the last of the 6 dimensions, is called recovery environment, where we're looking at where do they live, do they even have a place to live, what are their friends and family, are they supportive to recovery or not, do they have a job, do they have legal issues, do they have vocational, educational problems, so that we know how much family therapy to do, vocational counseling, liaison with the legal system, and so forth. Now, those are the 6 dimensions that drive the process of assessing a person's severity of illness and level of function, so that we, on the next slide, if you have those, and they have been sent out again for you to download if you're at your computer, so that we can then do treatment matching to do an individualized treatment plan. So we're looking at the slide 6 now, where many people will need motivational strategies because they aren't always ready to accept that they have an addiction problem. They may think they have an alcohol problem but not a marijuana problem. They may think they have a depression problem but not a schizophrenia problem. They may think that they don't have an alcohol, marijuana, or depression problem. They have a probation officer problem. But that means then that we're going to have to engage them in a change process. We want to manage all of the 6 dimensions. If you know that somebody needs to see a primary care physician on dimension 2 biomedical, are they getting there? Do they have money in terms of dimension 6 to pay for medication? Do they have transportation? We have to case manage all of their needs. In the individualized treatment plan, they may need medication for withdrawal management. They may need medication for their physical health treatment on dimension 2. They may need psychotropic medication for mental health needs on dimension 3, and they may need anti-addiction medication for dimension 5, the relapse dimension. Anti-addiction medications such as Antabuse or disulfiram for alcoholism. There are other anti-craving medications like Camprel or acamprosate or naltrexone, or what is in an injectable extended release form. Vivitrol is the trade name. There, of course, are nicotine replacement therapies, and there is, has always been for a while, methadone for opioid use disorder, and also buprenorphine. So a variety of medications that can work for the relapse dimension. We talk about self-help, mutual help meetings. People may need that for dimension 2, for their diabetes support group, for their fibromyalgia support group, for their cancer survivor group, or their HIV support group. They may need self-help, mutual help meetings for Dual Recovery Anonymous, for Dual Diagnosis Anonymous, for Double Trouble meetings, Emotions Anonymous, in other words, support groups for mental health recovery. And then, of course, there's AA and NA, and for family members, Alateen and Al-Anon, and so forth. And then, of course, we have to monitor all of the 6 dimensions to treat the changing severity and functioning as a person moves through treatment. Then you've got to do treatment somewhere, and the ASAM criteria has 4 broad levels, level 1, 2, 3, and 4. And in the new edition, we used to have Roman numerals for the levels. We now use regular Arabic numerals, 1, 2, 3, and 4. 1, outpatient treatment. Level 2, intensive outpatient and partial hospital. Level 3 are the residential and inpatient treatment levels, and level 4 is the most intense and for the most severe, the medically managed intensive inpatient treatment level, like a acute care hospital or a closed psychiatric acute care unit. Now, to quickly go through just what a continuum of care is in the ASAM criteria, I'm going to breeze through this fairly quickly, but I want you to get a sense that when we talk about ASAM criteria levels of care, we're really encouraging the use of a broad continuum of care so that we can increase access to care, not have waiting lists, but also spread resources across the whole continuum so that we can get good disease management and the best outcomes by really hanging in with people across a continuum. It's not about placing a person into a program from which they graduate and go to aftercare. It's about developing a continuum of services for good disease management focused on outcomes and function so that we all reach the goals that we want of decreased legal recidivism and increased public safety. So the first level I wanted to just mention is 0.5, which is about early intervention services. This is for people who have not yet crossed the line into addiction illness, but may be getting into problem with substances. For example, they might get their first DUI, or they may be, if they're a young person, having trouble at school using substances. They need education and risk advice. They need those impaired driving classes to get their knowledge base up, but they may not need formal addiction treatment if they don't have a diagnosis. Now, if you discover they do have a diagnosis in the course of those educational or classes around impaired driving, well, then, of course, they should get at least level 1 outpatient addiction treatment. We then also have what's called in the previous edition opioid maintenance therapy, OMT, but which is now called opioid treatment programs. And we won't go into a lot of detail, but in the new edition, we have a whole new section on opioid treatment services. For those of you who have the slides, we're on slide 8 at this point. And the opioid treatment services are made up of methadone programs that we call opioid treatment programs, made up of office-based prescription with buprenorphine, which is OBOT, office-based opioid treatment. And then we also include in the opioid treatment services chapter the use of antagonist medication, naltrexone, meaning it does the opposite of the drug. So if somebody's on naltrexone, that is occupying the opioid receptors. Then if somebody gets high with heroin or OxyContin, they won't get a reinforcing high because they already have the receptors filled with naltrexone, an antagonist medication. So we have criteria for methadone treatment, in other words. Then in slides 9 and 10, you'll see the 5 levels of withdrawal management, all the way from ambulatory withdrawal management without extended on-site monitoring. That would be like in a primary care physician's office. Ambulatory withdrawal management with extended on-site monitoring. That's level 2 WM, WM for withdrawal management. That would be like a day treatment or partial hospital where somebody is being seen throughout the day, but at night they have a safe place to go to, a family or a supportive living environment. If somebody needs 24-hour help through withdrawal, that would be 3.2 WM. That's clinically managed, run by not doctors and nurses, but clinicians who know when to call a doctor or nurse and have protocols for that. If somebody is more severe in their withdrawal, then they would go to 3.7 WM, which is 24-hour nursing care and a doctor available to see the person if necessary. And then the most intense level of withdrawal management, level 4 WM, medically managed inpatient withdrawal management like a hospital for somebody who is so unstable that they need 24-hour nursing and the doctor seeing them every day to manage and change their withdrawal management regimen. Those are the withdrawal management levels, and you can see that if you only treat somebody in the most intensive level, 4 WM, that could be $600, $800, $1,000 a day, Whereas if somebody needed 24-hour support in a 3.2 WM, a fancy one of those might only cost $200 a day, you could get 3 or 4 or 5 days of withdrawal management support in a 24-hour setting for what we now spend in 1 day at a hospital level of care detox center. And that is an inefficient use of resources if they don't need that. So we could give a person 2 weeks of support for the amount of resources we now spend in just 3 or 4 days at the most intensive and expensive level of withdrawal management. And if they don't need that, then we are not being good stewards of resources, and we're limiting the ability to manage the person's withdrawal over a continuum of care. Level 1, we're now, if you have your slides on slide number 11, Level 1 is outpatient treatment, less than 9 hours of clinical services per week for adults, less than 6 hours for adolescents. 2.1 intensive outpatient is for 9 hours of service a week or more for adults, 6 hours or more for adolescents, and 2.5 partial hospital is 20 hours of services per week for both adults and adolescents. Those are the outpatient and intensive outpatient levels. The level 3 services are the residential inpatient levels, and this is slide 12 now, where we're looking at 3.1, which is clinically managed low-intensity residential treatment, meaning 24-hour living support, where a person may be stable enough that they're not just going to walk out, they're not so impulsive that they're just going to walk out, and they need, though, 24-hour living support. So if they get a craving to use at 2 o'clock in the morning, there's somebody there who can work that through with them. If they are not able to be in that kind of supportive living because they're too impulsive, they may need one of the level 3.3, 3.5, or 3.7 residential levels. These, though, are for 24-hour treatment settings for people who would be in imminent danger if not in a 24-hour treatment setting. So we want to make sure that if they have cognitive difficulties, they're in a specialized 3.3 program, which is renamed in this new edition, clinically managed, population-specific, high-intensity residential treatment. This is for people with cognitive difficulties, traumatic brain injury. They may have dual diagnosis issues that make it hard for them to take the full intensity of a 3.5 residential setting. And then if they have physical health or medical problems on dimensions 1, 2, or 3, they would need to be in a medically monitored intensive inpatient setting with 24-hour nurses and a doctor available. If they are the most severe of severities, that would be level 4, medically managed intensive inpatient, a hospital level of care. So I know we're going very quickly, but I'll try to get through these and then open it up for some comments and questions. But that basically is the full continuum of care, and we just completed slide 14, if you have the slides there, outlining the continuum of services that make up the ASAM criteria treatment levels. Now I want to move on to slide 15, where we talk about models of stages of change, because I mentioned that dimension 4 is one of the 6 ASAM criteria assessment dimensions, which is very important, especially in a criminal justice population. It's important for anybody, but many people who are mandated to treatment are coming in not necessarily because they're interested in recovery, but because they're interested in many situations, getting off probation or parole, getting their kids back, and so forth. So I want to briefly remind you about stages of change, whether that be using a 12-step model where we're looking at, is a person surrendered or just complying? Compliance talk is like, well, how long do I have to be here? When will I get my letter? Can you give a good report to my probation officer, to the judge? That's compliance talk versus surrender, which is, with some pain and affect. Whoa, how could I do this to my freedom? How could I do this to my family? How could I do this to my health? What do I need to do to make some changes? Is the person just admitting or accepting? Admitting sounds like, well, maybe I shouldn't have punched her, but I told her to get away from me when I get this way. Or maybe I shouldn't be using these drugs, but it's not as bad as they say. So that's admitting a problem versus accepting a problem, which is, again, with some pain and some affect. Whoa, I really am appalled at what's been happening in my life. How do I change that? Is the person identifying or comparing? So compare would be, I never killed anybody, I never beat up my parents, I never lost my job. That's somebody comparing, I'm not as bad as them, versus identifying. I never killed anybody, but plenty of times I drove drunk and easily could have. Never beat up my parents, but plenty of times I was pretty violent and with the way that I spoke to them. Never lost my job, but plenty of times I was depressed and just sat there and not very functional. So when we hear people talking this way, rather than thinking about denial, resistance, and unmotivated, we're talking about, oh, they're just at a different stage of change where we need to help them work that through. You'll see in the slide on page 16 a diagram that comes out of a book called Changing for Good by Prochaska, DiClemente, and Norcross. And this is outlined the trans-theoretical model of change where people move from pre-contemplation, I don't have a problem at all, I'm not interested in changing, to contemplation, where they're ambivalent, maybe I have a problem, maybe I don't, maybe I want to do some work on this, maybe I don't, to preparation, I've got a problem and I'm going to work on it, and they mean in the next few days or weeks, to action, where they're actually doing something about their problem, to maintenance, where they've changed for 6 months and now have a pattern of good functioning, but now they have to make sure they don't relapse, and then termination, where they've made some changes. And other ways you can think of stages of change is that they're not ready to change, pre-contemplation, unsure about changing, contemplation, ready to change, preparation, trying to change, action, doing what works, maintenance. Now, the importance of this is that when we then interface with criminal justice, and now we're on to slide 17, the mission of criminal justice is correctly consequences, compliance, and control, in the sense that you can't have laws of the land where if people don't have to comply with them, because we're trying to control public safety and there need to be consequences if you break the law. But when it comes to mandating people to treatment, it's important that the treatment providers don't take on a consequences, compliance, and control mentality. We're really talking about individualized treatment, improving function and outcomes so that you get somebody who's not going to threaten public safety and who's going to do less crime and increase public safety. Now, this means then, and I'm on slide 18 now, that when we work together in drug court with providers, that we have a common purpose and mission. That is to get people to change in their functioning, to increase public safety, decrease legal recidivism and crime, increase safety for children and families, and increase accountable, real change that is going to be sustained so that people make the right decision in the dark of night, just not when they're mandated for treatment or when we have enough pressure over them. So we have the same common purpose, but because people on Dimension 4 are often at different stages of change, we have to have a common philosophy about how we work together to actually get the outcome that we all want. So that means we need the leverage of the court to work with providers and the clients to actually make some changes. And because we come from different settings, there may be communication and conflict resolution things that we're going to have to talk about. But we're all actually on the same team trying to get the same goal. And what this means then is that the treatment process starts with, on slide 19, what is the treatment contract? What is the client a participant about? What is it that they want? And on slide 20, it's really emphasizing that to engage a person in a true self-change process, we have to start with what is it that you want in an honest way. And sometimes people get mandated to treatment and they say, I want to be clean and sober, but then we say, well, why now did you decide to be clean and sober? Well, the judge said, if you don't go into treatment, you're going to do more time. And so what they really want is to do less time, not necessarily to be in recovery. And they have their ideas about how they're going to do this and where and when. Well, I'm just coming into this program and sort of do what you tell me to do, and then I'll graduate, and then I'll be able to do what I want to do. Well, we want to emphasize that joining with a person with what they want is where we start, and then in slide 21, you'll see that we move from what do you want to then making sure that you're safe. So we look at the 6 dimensions to make sure they're not in severe acute withdrawal or suicidal or homeless or whatever. If so, take care of that. If not, we go back through the 6 dimensions to do a multidimensional assessment. And then on slide 22, we want to know, do they have the diagnosis of addiction or a substance use disorder? Do they have a mental disorder needing mental health treatment? Do they have a physical disorder needing physical treatment? Or do they need addiction, mental health, and physical health treatment? But the diagnosis doesn't drive the treatment. It tells you they need treatment and what kind of treatment. What drives it is their particular multidimensional severity of illness function and level of function profile, which assessment dimensions are most important. Then on slide 23, what do we focus on in treatment? What specific services do they need? Do they need mental health services, physical health services, motivational services? What dose of that, how often and frequently they need that, will tell you in slide 24, what is the least intensive but safe level of care that we can provide that, and then we have to see how it progresses. And so putting it all together on slide 25, you can see that if you were concerned about dimension 3, specifically they were depressed and they needed mental health services, but they were not so impulsive and suicidal they needed a big dose with people watching them, then we could do that in an outpatient treatment setting. So the level of care is really the last decision about where to place a person based on the individualized treatment plan, which is based on an assessment of the 6 dimensions, and which is then done in conjunction with building an alliance with the person. I will help you get off probation, but let's look at the areas that you keep getting into trouble with so that we can treat those so that you will have a better chance of having a good outcome and not threatening the public safety. The slides 26, 27, and 28, I won't go into a lot of detail in the interest of trying to have some discussion time, but basically this is saying to assess relapse and Dimension 5 severity. Dimension 5 is relapse, continued use, continued problem potential. To assess Dimension 5, there are specific areas we can look at. How long has the problem been going on? Have they had a good response from treatment before or not? Do they use drugs because they're just trying to still get high and it still gives them a high and they get a lot of positive reinforcement from that? Or are they using because they're just trying to stave off withdrawal symptoms? And so if we could get them cleaned out, they may not be so inclined to go back because it doesn't do anything for them anymore. Or on slide 27, are they using because they get very reactive to acute cues? They see a beer ad on TV and they get a craving to use. They walk by their old neighborhood and they get a craving to use. Do they have a lot of chronic stress? Homeless, no money? Do they have problems with their locus of control, meaning do they see everything as being externally caused? suddenly I was in the bar drinking, I don't know what happened, versus internally caused. It was me who was the problem, going to a bar thinking I could play darts and just have ginger ale. No wonder I started drinking again. What is their self-efficacy, their ability to be confident that they can make changes? Many people we work with have very low self-efficacy. They don't think that they could make changes even if they wanted to. They've been told they're a loser, they're hopeless. And then finally, assessing their relapse potential. What are their coping skills? Are they able to say no to friends? Are they able to cope with negative feelings without picking up a drink or a drug? Are they impulsive? Or are they passive? Because that's going to impact their ability to stay away from addictive behaviors or drugs in the future. And then there are some resources that you can really look at in terms of e-learning and patient workbooks and journals, and the actual ASAM criteria book itself with a subscription-based web-enhanced version. And you can read all about that at www.asamcriteria.org. There are articles you can download, PowerPoint slides you can download, frequently asked questions. So please go to asamcriteria.org and get a lot of information there that we weren't able to cover in our brief time together here. So looks like we have, I think I wanted to leave, if we could, 15 minutes to open this up, and if you would unmute your phone, and I would welcome any questions or comments or disagreements or anything that I went over so quickly there, especially as it relates to working together in drug court with clients and participants. Do we have any questions or comments or disagreements?
Would you mind going over the level of care quickly between 2 and 3?
Yes, the levels of care between 2 and 3. So if you have the slides there, this would be taking a look at the slides numbers, let's see, slide 11 and 12 and 13. So the outpatient levels where somebody is getting less than 9 hours of service a week. It might be individual plus group therapy. 2.1 is intensive outpatient, which is 9 hours of service a week or more, so that they might be coming 3 hours a day, 3 days a week. 2.5 is 20 hours of service, where they are coming there pretty much at least 5 days a week. If it was a pretty intensive day treatment, that could be 7 days a week. For 5 hours a day, that would be 35 hours, and therefore would not be 2.5, but might be 2.8 or 2.9. We are using those decimal points as a way to indicate intensity of service. And then the residential levels, except for 3.1, which is 24-hour supportive living, the residential levels are really for people who need 24-hour treatment because they'd be in some imminent danger. So in the ASAM criteria, if you have somebody who, when they use, they get psychotic or they get suicidal or they get aggressive, and that likely is to blow up in the very near future, we're talking about hours and days, not weeks and months, then residential treatment would be where they would go for 24-hour treatment. But then as soon as they don't need that, we would want them to move through the continuum of care. Did that answer it, or come back at me if it didn't?
After that, what if they can't stop using?
What if they can't stop using?
If they can't stop using, that would be a dimension 4 or 5 issue. In other words, they may not be able to stop using because on dimension 4, readiness to change, they are not convinced that they want to stop using. Right. So sometimes when people get positive drug screens, that's not a relapse issue. They have not been all that convinced that they want not to use. So you have to do an assessment on why you keep getting positive drug screens. Is that because you're not all that interested in not using the marijuana, or you're interested in stopping methamphetamine but not marijuana or whatever? Now, somebody on dimension 4 may say, no, absolutely, I want to stop everything, but I don't know how to do that. on dimension 5 and 6, all my friends use. On dimension 6, that's recovery environment. Or on 5, they have any one or combination of the things that I talked about in slides 26, 27, and 28 that is making it hard for them to really maintain any abstinence. And then what do you do about that? Well, it's just like anything else. It depends on the severity and what the treatment plan is. Sometimes people can take care of that by going to more self-help, mutual help meetings like AA and NA, and increasing the frequency of their visits in an outpatient or intensive outpatient setting or partial hospital. Sometimes it's so overwhelming to them that they need to be in a 24-hour setting, and that's what 3.1 would be about if they just need a safe place to be, or if they are having such overwhelming impulses to use and that's making it dangerous, they need a residential setting. So when people can't use, that's an assessment and treatment planning question, and the level of care then depends on what needs to be done. Sometimes we just automatically say if somebody's not got a good outcome, they need to go to a residential or more intensive setting, and that may be true, but just like with your blood pressure or if you get depressed or suicidal, you don't automatically have to go to a more intensive level. It depends on how you're going to change the treatment plan and where can that best be delivered.
Okay. Thank you.
Yes. Other comments, questions, disagreements?
Razors, none of that. All you're going to bring is your ID and your medication. And if you smoke, pack a cigarette.
All right. We've got somebody, we can do a consult. Somebody's talking to somebody there. What about from people who are from criminal justice? I don't know if we have some judges or probation officers or attorneys on. We'd love to hear, because one of the things that I always encourage the court to do is to mandate assessment and treatment adherence rather than to mandate a particular level of care and a particular length of stay. The reason for that is that if you mandate a particular level of care and length of stay, the participant, the patient, the client often is then more focused on doing time than on doing treatment and change. And one of the things that we need to hold providers more accountable to is don't let a person just sit in your program doing time. That's not going to create change and get the goals we want. Make sure that they're doing treatment. So if you have a participant sitting in group and we ask them, what is your treatment plan, and they just look blankly at you, that may mean that they're not doing treatment. We have to say, well, what are you working on? And if you're not doing treatment and change, then we have to let the court know that you may need a graduated sanction, not because you got a positive drug screen, but because you're not doing treatment. But that means, though, that we have to hold people accountable to doing actual treatment and change. Now, if the client says, well, I'm here, aren't I, in the program, well, yeah, that's doing time. That's not doing treatment. What are you working on that will increase public safety? What are you working on that keeps getting you arrested? And that should be in an individualized treatment plan. Now, if they do get a positive drug screen, again, I would encourage the court not to sanction that, but to first ask the provider, is the person doing treatment? If they got a positive drug screen, that's a poor outcome. That means that you have to assess why is that outcome poor and what are you going to do differently in the treatment plan in a positive direction. And if the participant is willing to do that, then we continue with treatment. If they're not willing to change their treatment plan in a positive direction, well, then they have a right to choose no further treatment, but then they are out of compliance with the court order for treatment and should be sanctioned. So this is a fine distinction between making sure we don't just place people into programs from which they graduate, but to put them into treatment for which we hold them accountable for function and outcome. And when it's focused more on time, what invariably happens is both staff and participants are kind of just watching the time rather than focused on treatment and change.
Okay, we're a drug court from Texas.
Okay.
And what we do is we do case management, and there's the treatment aspect of the program and case management.
Sure.
Now, sometimes our clients will do what they're supposed to do in treatment. They're attending, they're participating in the groups, and then they're even doing their homeworks or assignments and giving good answers. But then in the case management aspect, they're not meeting those case management goals. Does one
What
have
would
to
some of those goals be in case management? What would some of those
recovery support, involving themselves in some sort of level of recovery support, pairing with a pro-social group,
yes,
employment, stable housing,
yes,
interpersonal relationships, parenting,
okay,
those types of stuff.
So those criminogenic factors and stuff.
Criminogenic, yes.
Yeah. So what is your question then?
So if they're not really meeting those criminogenic needs, but they're compliant and participating in treatment, does that have anything to do with responsivity to treatment, or how is it that be managed?
Well, you see, this is where it's important to work as a team, because if a person's still hanging out with the wrong crowd and is not taking steps to become self-sufficient, those are indeed treatment issues. I mean, they're not separate from treatment. They shouldn't be separate from treatment. Those criminogenic factors that you talk about really cross-reference to all of the 6 dimensions, because work, relationships is a dimension 6 recovery environment issue. Substance use, they may be not doing that while you're watching them, but if their attitude hasn't changed, that's a treatment issue. So we want to make sure we bring those case management criminogenic factors into treatment. If a treatment provider is just saying they're compliant with all the groups, but they're not working on changing their friends, changing job, looking at where they live, then I would hold the treatment provider accountable that they're not, at least by ASAM criteria, they're not doing ASAM criteria type treatment. They're just plugging a person into a program. And really, we don't want in treatment a person to comply, because Webster says to comply is to act in accordance with others' wishes and with rules and regulations. If you're just getting reports from providers that they're compliant in the program, kind of not causing any trouble, but they're not actually changing the people they hang out with, working on where they live in a safe place, working on getting income and not doing that in illegal ways, and all of those issues, attitudes, anger management, all of those things, those all should be part of treatment. So there should be a good correlation between a person's progress in treatment and the case management criminogenic factors. And if you're not getting that, that's why we need to work more closely with providers and hold them accountable to doing change, not just plug them into a program.
Okay, because there was a concern about that treatment was saying that they're meeting their treatment goals, but they're not meeting our case management goals, and they wanted to go ahead and promote them into the next level of treatment, where we were saying, well, shouldn't they be meeting all the criteria before that promotion takes place?
Absolutely, and your confrontation, or not confrontation, but your collaboration with treatment providers to say that these 2 things aren't separate. They're all about improving function and outcome. It's not like there are treatment goals and then there are case management goals. All of those have to do with the 6 dimensions in the ASAM criteria for holistic improved function. So you can't be reaching your treatment goals and not be reaching your case management unless the treatment is not really doing good holistic treatment.
Okay. Then another question we have is that we have a lot of marijuana users who may be using like 3 blunts a day. They'll come into the program, they'll test clean, then test positive, and then a couple of cleans and positives again, and then so it's showing us that they're not really responding to treatment because
Right.
there's like a type of continuous use, and
Right.
and I don't think that relapse class is really the answer at that point. I think you said it would be like motivation and
Yep.
adjusting their treatment plan. Then a
Yes.
lot of our response might be that they may need a more structured level of treatment to help them, because let's say we had a case of a young man, 20 years old, who's living at home, didn't have a job, wasn't going to school, still hanging around with a negative peer group,
Mm-hmm.
and using marijuana, and he was an ambivalent. There was a part
Yes.
of him that wanted to stop, and he says that he uses even though he doesn't want to.
Yes.
And then there's another part of him that felt that what we were asking of him was too much and that he had rather just,
Yes.
blow it all off.
That's
So,
right.
yeah, can you give us some sort of direction of that? Would a more structured treatment been appropriate?
Well, not necessarily, because you first have to assess why is he keeping getting positive drug screens, and you said it. What you talked about on dimension 4 was that he's ambivalent still, right? Now,
Yeah.
if you increase the structure, that's not going to make him more motivated necessarily. And sometimes when
Okay.
you put people like that into more structure, all they do is disrupt the program and then try to bring stuff into the program. You also mentioned on dimension 6 that he's hanging out with the wrong crowd and that he's living at home and not working. What is the treatment program doing to meet with the family to set some limits? What is the treatment program doing to work with the family to say, is it okay for your son to stay there and you pay for his food and lodging with no accountability for getting a job? In other words, family work needs to be done. That's not going to happen just because he's in a residential program. It may be that he, on dimension 5, part of him wants to stop, but he doesn't have good coping skills to say no to friends who offer him. But that work needs to be done. That can be done anywhere. That doesn't have to be done in an inpatient setting. But primarily, he may not even be trying that hard on dimension 4. He could have co-occurring mental health issues on dimension 3, which means that when he gets anxious, he thinks about using a drug rather than... In other words, it's a multi-dimensional reasons why people get positive drug screens. And the next step is to assess what that is and then do treatment on that. So as a drug personnel, we should be asking providers to say, have you seen the family? Is the family willing to set some limits? Are they okay with him just not working? And those things are the ways that we begin to do an individualized plan looking at the 6 dimensions, not thinking, well, we'll put him in residential as if that magically will motivate him. It may not.
Okay.
Now, if he says, I'm trying the hardest I can, but I just get overwhelmed with friends, and unless I'm away from them, I don't have a clue or a hope of doing this, well, then, yeah, that may be needed in his treatment.
Okay.
But that doesn't sound like what he's saying,
Would you briefly highlight, please, when they talk about putting a client in the less intensive treatment?
Yeah, the least intensive but safe. So it isn't like, in other words, we want to be good stewards of resources. If you put in a person into a more intensive level than they need for their treatment, we're then using those resources inefficiently, which takes it away from other people who need it, or it takes it away from that person to be able to give them more care, which will improve the outcome. But it's not always that you have to fail. In the ASAM criteria, we don't have a fail first policy, which is you have to fail before you can go to another level of care. You should go to the level of care you need. And if you're in some imminent danger, you should go straight to residential. But if you don't need residential, to spend that money on something where somebody doesn't need it, then we increase waiting lists, we decrease access to care, we use resources inefficiently, and that then is counter to what we're trying to do to get a good outcome. So it's just the same as in the rest of healthcare. You wouldn't have a radical mastectomy if you could safely have a lumpectomy. You wouldn't want to take insulin shots if you could just take an oral medication safely. and we shouldn't give people a level of care that they don't need based on their assessment unless it is matching their severity of illness and function.
Okay, thank you so much.
Well, now we at our time. I'm happy to stay on if people want to keep talking for a few more minutes. But in general, we went over, I think, some of the basics. Obviously, in 45 minutes to an hour, you don't get it all. But I hope this has been helpful to you in getting you thinking and getting treatment providers to help you to do good, holistic, individualized treatment to get the outcomes we all want.
David, what is your contact information or email?
If people want to write to me, they can write to davidmealy@gmail.com. So DAVIDM as in Mary, EELEE, all one word, @gmail.com. DAVIDMEELEE @gmail.com.
Thank you.
David?
Yes.
Is Jackie Starr. Once again, I'd just, like to remind everyone that the Massachusetts chapter is very interested in working with drug court professionals, and we'd love to hear from them. And excuse the beeping from my car.
Good. Yes, so there's resources available, and certainly email me if I can help, and also look at asamcriteria.org. There's more resources there as well.
And David, this is Roberta Lease, president of NEADCP, and
yes.
I can't thank you enough. This was enlightening to me, and I'm sure to others, and you will definitely hear from us. I'm hoping we can put your slides and maybe audio or whatever we can put up on neadcp.org. We would
sure
love to do it. Thank you so very much.
All right. Thank you for the invitation, and thank you for the work that you're doing, and we want to remain a resource to give you ongoing support too. All right. Thank you, everybody.
Thank you.
Bye-bye.
Thank you.